Come in, sir. Ladies and gentlemen, this witness has been previously sworn to testify truthfully. Just have a seat. Absolutely.
Good morning. Can you tell us your name, please?
Hi, it's Julian, Julian Davies, Davies.
I'm going to hand you a copy of Defendant's Exhibit 46. Do you recognize that?
I do, that's my CV.
You know that's already been admitted.
Okay.
Do you recognize Exhibit 87?
Yes, that's my report.
Your Honor, I move to admit Defendant's Exhibit 87.
Any objection?
No, Your Honor.
Okay. Defense 87 is admitted.
Sure.
And could you look at Defendant's Exhibit 85?
Sure, and that's the PowerPoint.
Sir, as the Defense Exhibit 85, hard copy of it belongs to you, and I think that the introduction to the record.
Any objection to 85 for purposes of the record?
No, Your Honor.
85 is admitted for purposes of the record.
If we decided I'm going to give this to you,
Sounds good.
and we need it.
Great.
So let's go ahead and start with what your profession is.
Sure, I'm a clinical professor of pediatrics, medical doctor.
Okay. And pediatrician. So, can you tell me about your education?
Sure, my undergrad was at Yale. My med school was at the University of California, San Francisco School of Medicine. And then I did my pediatrics residency at Seattle Children's and the University of Washington in Seattle, where I now practice.
And what professional accreditations, licenses, or certificates have you been granted?
I have medical licenses in the state of Washington, which is where I usually work, as well as licenses in California, Florida, and Georgia. And for the purposes of this evaluation, the Texas Medical Board gave me a visiting physician temporary permit.
And do you currently hold any faculty positions?
Yes, I'm a clinical professor at the University of Washington, which basically means that I teach residents and medical students, but I have my own faculty practice. And it's a general pediatric practice with some specialties. I see a lot of kids with histories of adoption or foster care. And then I think most relevant to today is that I'm the pediatrician on a team at the kind of the original fetal alcohol spectrum disorders diagnostic clinic. And so I've been working in that clinic diagnosing children and adults with fetal alcohol spectrum disorders for about 22 years.
And are you giving any hospital positions right now?
Hospital, I don't do hospital work. Seattle Children's Hospital has me on staff, but I'm an outpatient guy.
Okay. And do you say your current teaching responsibilities do include fetal alcohol spectrum disorder?
Yes, and so at that diagnostic clinic, we do diagnostic evaluations, but we're also a training center. So we have teams coming in from around the country and actually teams from other countries who come in to learn about FASD diagnosis.
And do you have any affiliations or memberships in any professional organizations?
Yes, I'm a fellow of the American Academy of Pediatrics, and I'm board certified by the American Board of Pediatrics.
And your responsibilities include any organizations that address FASD?
Yes, I'm involved in planning conferences and teaching. There have been some conferences held in Seattle that I've spoken at, if that's what you're asking.
Sure, and well, on that same vein, have you given presentations on FASD?
Yes.
What about, have you been published in that area?
Yes, as well.
And have you been qualified by courts to give testimony on FASD before?
Yes, in about 9 states I've been qualified as an expert in FASD, including Texas.
And FASD, is that a recognized diagnosis?
It depends who you ask and what country you ask. FASD, or fetal alcohol spectrum disorders, our clinic uses as an umbrella term that describes the full spectrum of birth defects and brain injuries caused by maternal drinking. The diagnoses that we use are under that umbrella term, and there's a couple that you might be diagnosed with if you come to our clinic.
Sure. And there's actually, I'm not going to try to confuse people, but if you look this up, there might be some different terms for diagnoses than what you use, but they're the same categories, right?
Yes.
Okay. And I'm familiar with the other doctors too, so.
Yep.
Let's talk about, but there are generally accepted methods that you rely on to determine if someone has FASD.
Yes, at the University of Washington, we developed something called the 4-digit diagnostic code, and a lot of clinics around the country and the world use that, and it was developed in the mid-90s, and it's currently in its 4th edition.
Now, did you examine Tanner?
Yes,
And did you review records pertaining to him?
a lot of records, yes.
Did you review reports of other experts?
Yes,
And it's the ones that have been testifying so far, and they're coming up.
yes,
Are you being paid for your work in this case?
yes.
And what is your hourly rate?
It's $450.
Do you have know approximately how many total hours you anticipate billing in this case?
I think I've already billed about 30 to 40 hours, and I haven't added up my recent work, but it could add another 10 to 20.
Okay. Now, you kind of talked about FASD being an umbrella term, but can you talk about why is prenatal alcohol exposure important?
Sure. Kind of an interesting topic. You'll hear a lot of different things about what amounts of alcohol might be safe and whatnot. So I like to start out, before we get to diagnosis, about what alcohol can do. So alcohol is a teratogen, and that means it causes birth defects, and in particular can cause brain damage. One thing that's tough about alcohol is that the placenta protects the developing child from many things, but alcohol goes right through it. So the mother's blood alcohol level is the fetus's blood alcohol level. And unfortunately, once it gets in there, the mother has a liver that can detox, but the fetus doesn't have a liver that can detox the alcohol in the same way. So while it's in there, unfortunately, we know that alcohol affects the developing brain on a lot of different levels. It can kill nerve cells, it can send them to the wrong place in the brain, it can make brain structures smaller or deformed. It can really interrupt the really important connections between different parts of your brain. It can affect the signaling, the chemicals between nerve cells, and it can even do lasting damage after the pregnancy by setting up inflammation or locking or unlocking certain genes in the brain. So, yeah.
Does it matter like when during the pregnancy the alcohol is consumed?
It does. There isn't a safe time to drink, but we know that the riskiest time to drink is in that first trimester. In those first 8 to 10 weeks, you're dealing with an embryo, meaning that the organs are being formed and the foundation is being laid. And in those first 8 to 10 weeks, we see more brain damage resulting from alcohol. It's great to stop as soon as you can because there's continued harm in the second and third trimester.
Now let's talk a little bit about what's under that umbrella of FASD. What specific diagnoses are there?
Sure. The original diagnosis, and this was called out in 1973, is fetal alcohol syndrome, FAS. A lot of folks have heard of that. That's one where you might have physical features that show up. So you might have growth problems. There's this unique set of facial features that those 4 kids have. Evidence of brain damage or dysfunction. And that's what goes into FAS. That was the original diagnosis. But we've learned a lot in the past 50 years, and now we know that FAS is just the tip of the iceberg. And a lot more people have the brain injuries, but might not have those facial features. And so there are other diagnoses under that FASD umbrella, where you're talking about brain damage from alcohol, but you might not have those physical features.
Can you kind of walk us through those?
This one kind of breaks it down. So we talked about FAS, and again, that's only 11% of the folks we see in clinic. So the next one down is called static encephalopathy, alcohol exposed. That's where the brain damage is essentially the same as FAS, it's just that you don't have all those physical features. That's about 1/3 of the folks we see. But over half of the people we see, and it's the same amount from the animal studies that we did, half of our patients end up with neurodevelopmental disorder / alcohol exposed. And that's where the brain injuries are in the more mild to moderate range, and you have that prenatal alcohol exposure.
And just so the people who are really detail-oriented aren't asking, you've kind of done a ampersand showing a couple of the names for these, correct?
Right, so if you hear those from other experts, it's because there's different diagnostic systems that kind of alphabet soup, people have their preferred terminology. So if you've heard about ARND, alcohol-related neurodevelopmental disorder, or you might have a psychologist that's using the DSM book, and in there they say neurodevelopmental disorder associated with prenatal alcohol exposure, or NDPAE.
Tell me about the diagnostic criteria. What are you looking for when you evaluate someone for FASD?
So essentially, you're looking for those columns. You're looking for evidence of prenatal alcohol. You're looking to see if there's any growth impairments. You're looking for those facial features, and you're looking at the brain. And with the brain, you're looking at brain structure, and you're looking at brain function.
And are there other considerations?
Very much. You know, those are the things that make up an FASD diagnosis. But we also really like to do what's called differential diagnosis. And that's where you're thinking about, okay, but what are the other risk factors, maybe in the family history or other things that went on during pregnancy or problems at birth or things that happened in that person's life that could have led to similar problems.
Now, when you're looking at those other things, is it possible to have what they call, like, I guess it's comorbidity, or have more than one thing, or is this does this exclude other diagnoses?
No, in fact, we expect other diagnoses, and the research at our clinic suggests that if you come see us for an FASD diagnosis, you're 3 to 7 times more likely to have other major risk factors that could be impacting your brain. And so sometimes we say that FASD is like a adversity magnet, or the hits keep coming, which is that unfortunately we see high rates of other comorbid, meaning co-occurring diagnoses. So it's really common to have more than just an FASD diagnosis.
What type of professionals are involved in diagnosing FASD? Is that an individual or a group, or how does that work?
It can be done as a solo provider sort of thing, but it's better when you have other professionals in the mix. Mm-hmm. And so at our clinic at the University of Washington, there's me, but there's also a psychologist and sometimes a speech language pathologist or OT, occupational therapist, sometimes a social worker. So it's best done as a team approach, which in the sort of legal setting usually means that there's other experts like psychologists and speech language pathologists or brain radiology specialists. And so I take what they find and use it to come up with my medical diagnosis.
And your diagnosis, like you said, is medical, from the medical perspective.
Correct.
Let's talk, if you're ready, about prenatal alcohol exposure in Tanner's case.
Sure.
What's your evidence that he experienced significant prenatal alcohol exposure?
Right. So his mother, Melissa, in a sworn affidavit, said that she was 19 when she became pregnant with Mr. Horner. And she was about 8 to 9 weeks along before she knew she was pregnant. Before she learned she was pregnant, she would drink to intoxication on numerous occasions. And she would drink Jack Daniels and Coca-Cola all night. She then said that once she found out she was pregnant, that she stopped drinking alcohol, but she continued to smoke cigarettes and also use some cannabis to manage morning sickness.
And what does that mean for Tanner specifically?
That, unfortunately, is a high-risk prenatal alcohol exposure for the reasons we were talking about. Those first 8 to 9 weeks are when those crucial foundations of your brain architecture are getting formed, when those nerve cells are most vulnerable to alcohol. And that pattern of drinking to intoxication, drinking Jack and Coke all night, that's a high-risk level of alcohol. And so it's this pattern of drinking that the studies show is most likely to cause fetal alcohol impacts. And if you look at the studies for this pattern of drinking, about 40% or more of kids born from a pregnancy like this may have some of those FASD impacts.
Now, can we, let's go back to our diagnostic criteria. You said you got prenatal alcohol exposure. What about growth deficiency? How does that relate to FASD first?
Yeah. So growth is interesting. We see growth problems in about 1 out of 3 folks in clinic. If you see growth deficiency, that person's brain is 2 to 3 times more likely to be impacted by alcohol. So it's meaningful if you see it, but most of our patients don't have growth problems.
Now, what about Tanner? Did he show any growth impairment?
From all the records I reviewed, he did not have growth problems at birth or since. So he did not meet the growth criteria.
And you talked about the original diagnosis, the FAS, with physical facial features. How did they help you diagnose FASD?
For the facial features?
Yes.
Yeah. The facial features are interesting. If you have them, and you have to have all 3 of these pretty subtle facial features, it's pretty much only alcohol that does that. But we know from studies that there's really maybe just 1 or 2 days early in pregnancy where those facial features get created. So most of the folks that come see us in clinic, they don't have those facial features. Less than 10% of them do.
So basically, it can matter specifically what day you drank on.
Pretty much, it's day 19 or 20 of a human pregnancy.
And you said, did you already say how common are those facial features among the patients you see?
9% have the full face of fetal alcohol syndrome.
And Tanner does not have those.
He does not.
The other criteria we talked about was, I guess the next one, what evidence of brain damage do you look for in an FASD evaluation?
That's where, again, we're looking for, is there any structural evidence of brain damage? And that alone could get you to an FASD diagnosis. But we also really want to look at how the brain is functioning, right? And so when we're looking at the kind of scoring how impacted the brain is, we're looking at structural stuff and we're looking at functional things.
Now, we've talked to other experts about diagnoses being based on deficits. So is your diagnosis based on what's wrong with the brain and not necessarily what it does well?
Yes, it's the same here. In fact, we really expect an uneven pattern in FASD where you can have some deep impairments or deficits, but also some skills that are more normal.
And how do you determine structural evidence of brain damage?
That's where in clinic, the easy way is to take a head circumference. If you have kids, you might remember us doing that when they're young. That tells you how well the brain is growing. That was not present in the records I have for Mr. Horner. Sometimes we have the benefit of neurodiagnostic imaging, and I think you've already heard about that, but like an MRI or a quantitative EEG or a PET scan, these are ways that help us look at the brain structure and function.
Okay, so we said you don't have in his medical history a small head, and there wasn't any like epilepsy or things like that, right?
There wasn't at least any medically confirmed epilepsy. I think there were some seizure-like movements at one time after maybe a head injury, but there wasn't enough to say he has epilepsy for me.
Now, the jury has already heard from Dr. Lewine and Dr. Bigler. You're familiar with both of them, correct?
Yes.
And familiar with the reports that Lewine testified about?
Yes.
So, did the brain imaging show any abnormalities that matter to your diagnosis?
Yes. What you already heard about is that there are some areas in both his gray matter and white matter that are abnormal. And those are in areas that we see in the fetal alcohol spectrum literature. They're also described in other conditions like autism, ADHD, head injuries, and so on. So they're not unique to FASD, but they are potentially caused by maternal drinking. And so we saw that on the MRI. The quantitative EEG was looking at the brain electrical activity and how coherent it is, how well different parts of the brain are talking to each other. And there were some EEG abnormalities that are also potentially consistent with what we've seen with FASD.
So those abnormalities are there, and it usually is one of those conditions you just named.
Objection leading, Your Honor.
Don't lead your witness.
So the brain abnormalities are real.
Yes.
And you're giving the jury, would you give the jury that list of things it could be?
Sure. You know, again, on the imaging, there are multiple possible causes, right? So FASD or maternal drinking is one possible cause. But if you look at the literature for autism and ADHD and severe mood disorders and head injury, you can see some of those same areas of the brain being potentially affected.
And that is why you do further work to do your evaluation?
Yes.
Okay. So did you also look at the PET scan performed on Tanner?
Yes.
Did that reveal anything useful for your diagnosis?
He did have abnormal brain metabolism where some areas were working too hard and some areas were not working well enough. And those were areas that support memory and attention and the emotional regulation of your behavior and social understanding. And in fact, a lot of those other areas that we just talked about influence how well you do with those skills too. So what I found striking about the neurodiagnostic evidence was it lined up quite neatly with the things that have been challenging for Mr. Horner in his life and on the sort of functional testing that he's had.
Let's move on to that then. What functional evidence of brain damage do you look for in an FASD evaluation?
Sure. There are levels. You might remember that there's a severe brain dysfunction and then there's a mild to moderate range. And so what we're looking for when we're looking at scores, and these are when people see a psychologist and have a day or two of testing and get a lot of standardized test scores. If you have scores that are below the 3rd percentile, meaning that like 97% of people do that better than you, we call that a significant impairment. If you have skills that maybe 85% of the population does better than you, we might call that an area of concern. So in our FASD clinic, that's what we're looking for, is how many domains or areas of brain function are significantly impaired, and then how many are more areas of concern, and then to make it a little bit more complicated, sometimes something will be borderline, which is very close to a significant impairment, but not quite.
So borderline means between severe and mild moderate?
Yes.
Okay, so it's not like below it.
Yes, exactly.
All right, so have you identified areas of brain dysfunction for Tanner?
Yes.
Can you tell me about let's start with the brain domains of significant impairment.
The significant impairments, the first one is ADHD. He was diagnosed with it when he was quite young, about age 5, had a lot of visits, was on a lot of medications for ADHD. To me, that's a well-established diagnosis for Mr. Horner. And it sticks out to us because we see a ton of ADHD in our clinic. We know that half of kids born to moms who drink heavily end up with ADHD, but it's usually ADHD plus. ADHD is the first stop on the diagnostic train that sometimes leads folks to come see us. And so ADHD is definitely considered an area of significant impairment for us.
If you have a patient who's on the FASD under that umbrella and has ADHD, is that more difficult to treat?
Yes, we still use some of the same medications and treatment approaches, but they're not as successful as if you have more garden variety or genetic type of ADHD. And whereas folks with more routine ADHD, often things kind of get better as you get older, with folks with FASD, things often get more challenging in adulthood.
And what other area of significant impairment for Tanner did you identify?
He has a diagnosis of autism spectrum disorder, and I think you'll be hearing from some experts about that, but he was diagnosed young with that and continues to have it. And so we consider that the domain of social communication. He's also had some testing by a speech-language pathologist who's done testing of his language and found that he also has some severe impairments in his higher level use of language. So I put language and social communication together as an area of significant impairment.
Now, we had, I think Dr. DeWine and Dr. Bigler both talked on about the neural networks that affect language, and then the jury has heard from Dr. Fritz already too.
Oh, great.
That's kind of what you're talking about?
Exactly.
how that-
Dr. Fritz's evaluation, yes,
Sure.
led to that.
And would you agree with them that the brain basically controls behavior?
Yes.
Now, what about areas that are borderline?
Right. So one is that on his IQ scores, he has what we call significant splits, which is when you have a big gap between one type of intelligence and another. And in our clinic, if we see an unusual difference between those intelligence skills, we'll sometimes call that an area of significant impairment. And his splits were significant, and they were between his verbal abilities and his nonverbal abilities, as well as his kind of verbal and nonverbal intelligence and his processing speed. So some big gaps there, a very uneven pattern on his IQ. Sometimes in clinic we would call that a significant impairment, but I was cautious and labeled it borderline because I essentially didn't want to double dip, and I knew that his ADHD could affect those gaps, and I also knew that his language impairments might explain some of those splits. So that's why I called it borderline.
Now, the IQ testing, that's not testing that a pediatrician performs either?
No, that's a psychologist.
Okay, and so you relied on data from a neuropsychologist for that?
Yes.
All right. And I just want to clarify too, you put your original report into the record, and then after you received Fritz's report, did you do an addendum?
Yes.
And what did that make the changes you talked about?
You know, it didn't change his overall diagnosis at all, but when I got more evidence for the autism and the language, that moved up to a clear area of impairment. It had been borderline before, and that's when I cautiously moved the splits down to borderline. So they swapped.
Did we have other areas of borderline impairment?
Yes, tic disorder. He has described certain tics, and I saw some during my evaluation. And I believe Dr. Ryan was just testifying, and she may have mentioned a tic disorder as well. That's significant for us because tics are neurologically based. So when people have a tic disorder, we may give them an area of impairment for that. We know that tic disorders are about 5 times more common in folks with FASDs. And we also know that folks with tics are also more likely to have mood disorders like depression or anger episodes or meltdowns such as have been described for Mr. Horner.
And I apologize, did you have a slide you wanted to show on the IQ splits first?
It's hard to see here. Is this what you're thinking about?
That's what I'm thinking of.
Yeah.
And can you tell us who prepared that slide?
So the neuropsychological testing was done by Dr. Kaufman, and the graphing was done by a colleague, Dr. Connor, who does a lot of FASD psychology work.
And I'm not asking you to go to these because it's hard to read like you
Yeah.
said, but basically, what does the green line represent there?
Sure. The green line is average for the general population.
And then what's the red line representing?
That represents more than one standard deviation below the mean. That gets you into the area of concern range. That's at about 80, when you're in the 16th percentile or below.
And when you answered before that these kind of vary, is that what you're seeing here?
This is what we call in clinic a very spiky profile. He has some unusual differences in his IQ, which you can see there on the left. And you can see that some areas of brain functioning, he's got some normal things, right next to some areas that are, in the area of concern or significant impairment range. And some things that aren't on this are his diagnosis of ADHD, and also Dr. Connor didn't yet have Dr. Fritz's report, so you'd be seeing some lower scores for language there if it were on there.
Now, what other, did we have any other borderline areas of concern?
The IQ splits and the tic disorder are the borderline domain.
And in the other domain, what do we have?
So for areas of concern, and again, that's generally if you're in the bottom 16% of ability. There were some of his executive skills that were lowered. He definitely had some learning and memory scores that fell into that area of concern range, particularly short-term memory and facial memory. He had some visual perceptual skills that were in that area of concern range, and his fine motor abilities were also in the area of concern range.
And overall, is Tanner's profile consistent with FASD?
Yes, all the things that we've been talking about, we see all the time in clinic, including that uneven, spiky profile.
And which diagnosis specifically are we talking about for Tanner?
Sure. He has those 2 areas of significant impairment and 2 borderline, which means he's very close to the threshold that would get you to that severe brain dysfunction where we require 3 areas of significant impairment. But conservatively, I diagnosed him with moderate dysfunction because I only counted 2 of those as severely impaired, and that brings him to a diagnosis of neurodevelopmental disorder, alcohol exposed. And you can get that for mild to moderate impairments. He's definitely got at least moderate, and he was close to severe, and he was also exposed to alcohol in a high-risk way.
And I think you already touched on this, but NDAE, that's a common diagnosis among people with FASD?
Over half of the people we see have this diagnosis, and over half of the animals, which is not the happiest studies, but at least in those animal studies, you can control for all the other risk factors that humans have. You can kind of eliminate those and just look at what results from a known amount of alcohol. And in those animal studies, over half of the animals had the animal version of this diagnosis.
And what does that mean for Tanner?
Neurodevelopmental disorder, alcohol exposed, is a tough diagnosis to have. You don't have the physical features that might flag the attention of a pediatrician early on, right? So he wasn't tiny at birth. He doesn't have those facial features. So folks who don't have those facial features have later diagnosis. You might also be thinking, well, moderate, that sounds pretty good. He's going to do fine. But when we followed folks with this moderate brain dysfunction over time, we actually find that they're less likely to get appropriate diagnoses. They don't get often the supports they need, especially when they're trying to transition to adulthood and leave the nest and so on. And yet they're people that need those supports. And we've kind of looked at, we generate a lot of recommendations from clinic. And when we look at folks with this diagnosis, they get the same amount of recommendations as folks with more severe brain dysfunction. You also, might think that mild to moderate, that brain's probably okay. But when we do similar imaging studies, like Mr. Horner's had, we see that over 40% of people with this moderate diagnosis do have evidence of brain damage. So it is brain damage, and it does need help. And unfortunately, that help often comes later, if at all, because it gets missed.
Now, we talked about part of your process is a differential diagnosis. Can you explain that again and kind of let's walk through that in this case?
Sure. I think I've got a slide for that. Mr. Horner had a lot of risks and has a lot of diagnoses, and you're probably hearing from a lot of experts, so I appreciate your patience on that. As I said, folks that come to see us in FASD clinic have 3 to 7 times the number of these risks that folks in the general population do. And so when I looked at Mr. Horner's history, a couple things popped out.
Sure. Tell me about the family history.
So we know that he's got a strong family history of substance use disorders. And that, together with being exposed to substances while you're in the womb, really increases your own risk to have substance use problems when you get to adulthood. We also know that there is a family history of psychiatric disorders and suicidality, and Mr. Horner has suffered from similar things. Because of that family history and because of his autism, I did do some genetic testing because I was curious to see could we find a difference in his genes that would explain his outcome. And we did pretty comprehensive genetic testing and we didn't find a clear, aha, it's this gene that caused all of this sort of thing.
Did you talk about other potential prenatal exposures or things like that? Did you consider those in your differential diagnosis?
Not yet. You saw his mother's statement that she smoked and used cannabis as well. And when you look at all the things you could use during pregnancy, unfortunately, alcohol is common and legal, and it's the worst thing you can be exposed to. But those other things have risks too. So if you smoke during pregnancy, it can increase the risk for ADHD or antisocial behaviors. If you use cannabis or weed during pregnancy, it can affect your executive skills like planning and organizing. Also can affect your academic achievement and your risk for using substances yourself. But they are present, but not generally as dangerous as alcohol is here.
And what other differential diagnoses did you consider?
Sure. Another one that really jumped out as a prominent risk factor is that Mr. Horner's, and may I ask, has the jury heard about that yet?
Yes, Dr. Speck has testified already, so that they'll be familiar with that. And if you just want to
Sure.
act as if you had a conversation about it already.
All right, great. So you heard about lead. You know that his bone lead level was 24 times higher than other folks his age. And if you calculate back to what that would have been when he was a kid, that looks like a level of almost 30. That's really high. The lab flags a level of 3 for me. So his level as a kid is estimated to be about 10 times that. And I can tell you, I've been doing pediatrics for 23 years. I can think of only, and I order a lot of lead levels, I've only seen one result that high, and that was a child adopted internationally where there was a lot more lead. So for me, that was a significant risk factor because that amount of lead can impact your IQ, can impact ADHD-like symptoms, and unfortunately is linked to delinquency, aggression, and explosive tempers. So lead was a significant feature of his history for me.
I want to talk about the differential diagnosis of childhood trauma. Why does that matter? I believe Dr. Bigler mentioned trauma actually affecting the structure of the brain itself, its neural network. Can you tell me about that, please?
It matters because essentially you can be born with genetic risks or impacts from drinking and things like that. So you can be born with a brain that's damaged. But then there's further damage from neglect, abuse, and other adversity or other traumatic experiences in childhood. And we've looked at that because we see so much childhood adversity in our clinic. And we've tried to weigh what does more damage. And what we found is that alcohol is probably the riskiest thing, but that if you add up a lot of childhood adversity and these other risk factors, then they start to rival alcohol in terms of what does how much damage, in terms of brain structure and brain function. And so Mr. Horner's childhood adversity, which was very significant, added additional risk and added additional damage.
Okay, now next I want you to talk about ASD and FASD because I've asked you about you have both, and I guess there's different ways of identifying them, different ages they get identified, and maybe different support you could give for those.
You can absolutely have both fetal alcohol spectrum disorder and autism. And we're still learning about how much of a role alcohol might play in developing autism. We know that autism is primarily genetic in terms of the risk factors, but we know that there's other things during pregnancy that can increase the risk that someone's going to have autism. And what I can say is that from our clinic stats, if autism is about 1 to 3% of the population, well, folks that come see us, 10% already have an autism diagnosis, and 10% get referred for further evaluation. So it does seem like there might be some impact of maternal drinking, and there's also certainly some overlap in symptoms between autism and FASD.
Did you also look at potential brain injuries in Tanner's case?
Yes.
And how did you factor that into your differential diagnosis?
He's definitely had some head injuries. He got stitches at age 4. He unfortunately tended to hit himself in the head when he got really upset or was having a meltdown as both a child and an adult. He's reported that at times he knocked himself unconscious from punching himself in the head. He was knocked out in his mid-20s, passed out, and then there was a suicide attempt that involved strangulation where he was unconscious for some amount of time. So he's had a number of head injuries that could have added, harm to his developing or young adult brain.
And did you consider Tanner's substance use in your differential diagnosis?
I did, and when I do these forensic legal evaluations, we hear about a lot of substance use that often starts very early, with middle school or before. And so Mr. Horner did use substances, but for me was lower risk compared to other legal cases like this. Mm-hmm. He tended to prefer cannabis or weed and did use, a lot of that. He also used K2 or synthetic weed from about 18 to 23. And also has used some other things, but maybe not as much. So MDMA and psychedelics were things that he used sometimes. And more recently, before the instant offense, there was use of cocaine as well.
Did you have a chance to review mental health records for Tanner?
Yes.
And how did that factor into your differential diagnosis?
There was a lot there. There's depression, there's anxiety, concerns for bipolar, self-harm, suicidality, suicide attempts. And we know, unfortunately, that when you're going through life with disabilities and the risk factors that he's had, and the childhood that he had, and the family history that he's got, that we really unfortunately expect to see a lot of that. So in young adults with FASD, with his kind of risk factors, we expect to see those. But I don't think that those mental health diagnoses better explain, what we see on his testing.
So what was your ultimate conclusion from that differential diagnosis?
Right. So there's a lot on that slide. There's a lot we just talked about. When I weigh those, I know that the research tells us that alcohol is a dominant risk factor that in our clinics explains a lot of the brain damage and dysfunction. So we'll usually put that near the top of the list of culprits. But in Mr. Horner's case, we've got that really high lead level. We've also got autism. We've got a lot of childhood trauma. And so in terms of weighting those, this is one of those situations where you can't scientifically say 100%, I know what this risk factor did, right? I can tell you with my clinical and research experience that I do think that the high risk drinking caused at least some of what we're seeing. And in particular, I point at ADHD as a common result of maternal drinking. I point at those language difficulties and those IQ splits. I point at some of those behavioral and mental health challenges, but that's not me saying alcohol is the only thing that did those. I think we've got a mix of risk factors here, and I think his FASD diagnosis is part of a broader picture where his brain has had a lot of hits from before he was born to now.
And I know we've brought you in here to help give us a why and how Tanner's brain works. But ultimately, those abnormalities are there, they're structural, there's functional issues, and all that's present, and you are just trying to tell us kind of a root cause of it.
Yes.
Can I approach your Honor?
Yes.
jurors that I did not give this document for. Can you identify it? This is Defense Exhibit 89.
Yes, that's the addendum.
And I would move to admit this. Let me check.
No objection.
Thank you.
Defendant's Exhibit 89 is admitted.
I have nothing else here. I'll pass the witness.
Let's take a short break and then we'll call you back in, okay? About 10 minutes, all right? Yes, sir.
Okay, that was painful. That is the only way I can describe what we have just been listening to. I struggled, Keith, to stay awake. I mean, I was, we each went and got a cup of coffee to try to get our way through this. What in the world are they doing here right now?
All right, 10 till 3, everybody, 10 till 3.
I don't know. I really don't know right now. One, the lights are off so that the jury can see the PowerPoint of this guy.
Oh, how many of them are awake?
And I'm wondering, I mean, it was brutal for us, and we got these bright, shiny lights
and we can get up and move around,
everything.
and we can get a cup of coffee. And
I just don't know. I mean, even at best, I think at the very end of his testimony before they went to break, he said, well, drinking while pregnant could cause ADHD and some other disorder that he mentioned, but at the end of the day, it still doesn't get to the point of mitigating or explaining why this happened.
Right.
And he's been on the stand for I don't know how long, and
I don't know. I wish I had written down what time he went on the stand, because I feel like my brain turned to mush listening to him. I mean, okay, we get the idea. Tanner Horner had a crappy childhood.
Yeah.
Got it. I mean, enough said. Can we stipulate to it?
Right. And I don't know. And the time period of these questions for him, I mean, at some point, you've got to just see, okay, is this jury still engaged? Does this jury still look like they are paying attention to what our witnesses are saying? Do they seem like they understand? If they don't, then you need to change what your purpose is for this witness. You need to figure out how you can make them re-engage with this witness, and you probably need to get the witness off or shut down or tighten up the amount of time that they're going to testify. But now it's whatever benefit you think that this witness is giving, are you causing your side even more detriment because the jury is just so done with your witnesses?
They got another one.
They got another expert.
We haven't even gotten cross yet, folks.
Right.
Which I don't know what you cross on. I mean,
right now
you didn't examine Tanner Horner.
Right.
You said he had mild. Let me go back. Hold on. Let me go back to my notes. Yeah, you said he had mild something. Whatever it was mild.
I think it was the fetal alcohol syndrome. He said it was mild to moderate.
Yeah, and he talked
close
about
to
this
severe
neurodevelopmental disorder.
Okay.
And it was moderate.
Okay.
And I'm like, okay, folks. This is okay, folks. I'm reading your comments. I do not have Apple Pay. Please do not send me anything. Don't get me in trouble with my bosses. I'm looking at your comments going, I appreciate it, and I know at times this trial has been painful in a lot of different ways. Right now it's painful because this expert is just, I don't understand why we're putting everybody through it. But I do appreciate y'all thinking about me. But I just happened to look down and read that comment and go, oh no, please don't start sending me stuff. I could just imagine my news director coming out and going, what is going on?
Right.
No, I promise I didn't solicit anything.
Right.
But I will say we did have a moment of levity. Rebecca even texted us that one of the jurors was laughing during this inmate's testimony.
Right. And we were talking about the inmate testifying, and I've been doing this 23 years, and I told you I've never seen a witness testify like this, like just an inmate that happens to say, hey, I'm just going to go be a character witness for my cellie, my guy next door, and talk about us communicating and how I'm always trying to keep his head up. And I wake up to use the restroom and he's pacing the floor and everything, so I know it's tough. I've never seen anything like that, and it sounds like the jurors hadn't really seen anything like that either from what Rebecca reports.
But you told me you said to me while we were listening to that testimony that you thought that inmate was more credible than Dr. Ryan.
I did. I thought that inmate, to me, came off more likable than Dr. Ryan, because, I mean, he just said what it is. I mean, he said, look, guards have tried to tell me what this guy's accused of. This guy didn't tell me what he was accused of or didn't give me the facts. I just try to keep him encouraged. We encourage each other. I try to tell him what it's going to be like when he gets to prison, and that he needs to stay in his lane, I think is what he says.
He called him a cool little white dude.
A cool little white dude.
I fell out of my seat.
I think that is the part where he does probably get some likability. He just shot it like it was.
And we have Rebecca calling in. Apparently we haven't figured out V-call.
Yeah, I'm still having issues, Tanya, with the V-call.
Well, Keith and I have just been, we chuckled about the inmate, and I told folks what you said about the juror laughing, because we thought the best part of it was when he called him a cool little white dude. And then we both...
Tanya, let me tell you,
Well, you're telling a lot of people out there too, but go ahead.
Yeah, I went in there specifically because I wanted to hear and see the jury, and I'm telling you, there were at least 3 jurors were snickering, that were laughing throughout that entire testimony with the inmate. I'm not sure what in the world that added, because no one took him seriously. The one juror, he was laughing so hard that he almost couldn't compose himself. He was holding his in his hands, and he was like shaking, trying to keep from bursting out laughing in the courtroom. But some of the other jurors were laughing, and others were snickering. Some looked kind of ticked off. Others just looked like indifferent. But no one took that guy seriously. So I keep thinking the defense is hurting their case.
Keith and I both agree, and I will say this. For the sake of this jury that has listened to all this testimony, and they can't talk to one living soul about it, maybe this moment of levity, right? Because we haven't had any moments of levity in this trial, right? Because this trial is awful. And so, right. I don't know.
I think that they were just the reason they were reacting the way they were reacting is that they just felt like this witness's testimony was so ridiculous and just a place. And that's the reason I think the jurors were reacting the way that they were reacting.
Well, and Keith also said, and you can repeat this to Rebecca, that he had never seen anything like that in 25 years.
Yeah, I've never seen an inmate just testify just for the sake as a character witness. I've never seen an attorney call an inmate as a character witness for someone, especially just because they just happen to meet each other in the jail. So that was just something I've never seen before. Again, I don't know what the thought was there, but I guess if that's who you got, that's who you got.
I'm sorry.
And I go back to the fact, Tanya, that they did not call his brother. There's got to be something that made the defense pull him from their witness list, because he was set to testify for this entire trial. In fact, during some of the pre-trial stuff, they were trying to figure out how they were going to do the Zoom call from TVCJ and how they were going to get his call in so that he could testify as a character witness. But the defense decides not to call the brother. So something has happened in these last few days that made them pause about calling the brother. Maybe they had issues. Maybe the brother's going to testify to something that the defense thought, we better not open that door for the prosecutors. But they pulled the brother as a character witness and got this guy instead, which basically the jury thought was a joke.
What do you think, Keith?
Rebecca, I got to ask you this. I mean, he kind of came off a little bit likable to me, just because this is what the jail life is, and so I don't want to say likable like I'd have him at my house for dinner or anything, but from a standpoint, from all the witnesses that they've put up right now, I mean, he seemed to be the one that would answer the question and just told it kind of like it was. What were your thoughts? I mean, obviously the levity to him testifying, but did it seem like, I mean, were the jurors just totally disregarding him, or just from a standpoint of it's come to this that we now have a celly coming in and testifying?
Yeah, but there was a couple of jurors that are just more stoics. You can't really tell what they're feeling. But there are some that are very obviously did not really take this guy seriously. And I also think at the point where he said he's got great character, he's a great guy. This is a man who murdered and strangled a 7-year-old girl for an hour, and for this person to stand up and sit up there with his own issue of victimizing people, saying, "Oh yeah, he's a great guy," and blah blah blah. I just think it just did not land well with this jury.
Well, and that inmate had spent 13 years in prison, had another 7-year stretch to go, and they were based on his description, they must have been in some sort of administrative segregation, because he described that they were in cells for 24 hours a day. Probably they get out like an hour. Usually there's some laws about how often they have to get out per hour to have some sort of recreation, but this made me think that they're in some sort of heavy duty lockup, and that guy had an orange suit on, and I can't remember in Tarrant County not an orange suit, a red suit, but in Tarrant County a red suit tends to be.
It usually means that they're like an aggressive risk, like maybe a violent person from a standpoint, or that they've had an incident where that has it basically warns the guards that this is a person that you need to keep an eye on.
Right. And so
Yeah, I'll find out the answer to that. He was shackled. Now he was shackled and handcuffed because you could hear the chains rattling on his feet as he was walking by, on his legs rather, as he was walking by. He was shackled and handcuffed, which Tanner Horner has not been this entire time.
What'd you think of the our fetal alcohol syndrome expert? Because Keith and I were just sitting here looking at each other and going, "What is the point of this?"
Because we've heard this over and over again. I mean, it's the same. It's just, I told you, remember that when we were listening to these experts before, or I did, during the hearings, they all read each other's reports, and they're all testifying off of each other's reports, and some of them did affect it. Yeah, but he's coming back into the.
Hey, I appreciate you, but we getting sound, and Tanner's coming back in the room. All right, thanks, bye.
I know, yeah.
All right.
Well, I got two up here. Huh? Over there? I told her to. But there's something here. Yeah. Go, do that. See if she does. All right. Both sides ready for the jury? Well, I lost Carrie.
Yeah, okay. Yes, sir.
Y'all want to sit down if you see him coming?
He's a patient, Your Honor.
Who is?
King.
Oh.
There he is. I do have it on the flash drive, but it's on my big.
All right, let's talk some more about that inmate. You had some stuff you wanted to say, Keith.
Oh yeah, the inmate. You know, one thing that he said that I can totally see the levity with the jury is when he said that I guess he was going to go catch his chain because he just signed up for his 7 years, which that means that he's about to go to prison from the jail.
He's about to go to TDCJ.
And so he said that that Tanner looked at him like that puppy dog looks at you, like why you leave him kind of deal. And I just thought, great. I mean, that's why he seems kind of like you just believe what he says. Now, you might not believe his opinion on things, but what he tells it like it is.
Yeah. So that was definitely a moment of levity, and of course the little white dude part was the part I laughed at the most. Just
cool little white dude.
Yes, a cool little white dude. I just about fell out of my seat.
Right.
Okay, so we're getting sound back in that courtroom. We should be starting back up with this fetal alcohol syndrome witness, and I assume we're going to cross-examination. All right, kill our mics.
Cross-examination, Mr. Berry.
Thank you, Ryan. Good afternoon, Dr. Davies.
Good afternoon.
Welcome back to Texas.
Thank you.
You've been down here a couple times, correct?
Yes.
You've recently testified on capital murder, correct?
Yes.
Here in Tarrant County?
Yes.
And at that time, I think you were more testifying on your expertise related to adoption services and things like that.
It was both. There was FASD question and international adoption questions.
Understood. So I want to talk to you about kind of what you know about this case and where you know it from, all right? Now you, as an expert in this case, are excluded from the rule of witnesses, correct?
I believe so. I haven't seen any other testimony.
You have not watched 1 minute of the testimony on live stream?
No.
And you haven't seen any of the other experts testify?
Correct.
You haven't heard the prior sexual assault victims of Tanner Horner testify?
No.
Correct. You haven't seen any of the evidence in this case other than just what you're here right now?
I mean, I've reviewed a lot of records, but I haven't seen the testimony about them.
Understood. So I want to talk about the records that you did review. There's a list in your report of the records that you did review, correct?
Yes.
And I think if you look at that report, it would be the last couple of pages of that report.
Yes, sir.
I want to ask you about a couple of things on that list of records that you reviewed. There's a lot of hospital records, correct?
Yes.
There's a lot of records from other experts that may or may not have already testified in this case. Is that right?
Yes.
There are some different genetic sequencing reports, things like that.
Yes.
There is, it looks like TEA records. Does that sound correct? I just, looking at page 35 of your report, it talks about PRU 822 attendance, and then the next one is discipline, the next one is graduated, and I think the next one says special ed, is that right?
Yes.
So you've reviewed those education records.
Yes, what's available, yes.
Okay. Is that where you got all of your information, from the actual records themselves, or did you have other sources of information that you were relying on in making your conclusions in your report?
I would say that the records reviewed here and then the additional records in the addendum, plus I recently received Dr. Ryan's report, plus my interview and examination with Mr. Horner. That's where I got my information.
Well, in those records that you reviewed, did you also receive something that was called a social history?
Yes.
Did that lay out a whole bunch of facts related to Tanner Horner and his background?
It was a summary of his family background and his childhood, yes.
And who produced that summary?
That was his legal team. I think that summary was written by Patricia Rist.
Okay, so you were relying on facts provided to you about the defendant's background that were given to you directly from the legal team with no notations as to where they came from or where this information was gathered from or anything like that, correct?
I think that the point of that document was to summarize the really extensive documents in this case, and so I would say that for most of the things I might have gotten from the social history chronology, there were also primary sources or other records that I relied upon as well.
Understood, but in your notations, you cite to this numerous times, this social history that was provided to you by the defense in this case, correct?
Yes.
And so if there were things left out of that social history that were relevant in this case, you would not have known about those things, is that correct?
Well, I might have known about them from interviewing the client or the thousands of pages I reviewed of other documents.
But if it wasn't contained in those documents and it wasn't provided to you by the defense, you wouldn't know about it, is that right?
Most likely, yes.
Okay. And so let's talk about your interview of the defendant in this case. Kind of tell us, how you set that up, what were the logistics of how that took place?
Sure. So this was in a contact visit room at the jail. The visit was semi-private. I think they monitor with the CCTV, but I don't think that other folks were listening. I was introduced to the client briefly by one of his attorneys, but then it was just me and Mr. Horner. And we spent about 2 hours and 45 minutes together. That included my medical interview as well as my physical exam and taking some photographs.
Okay, so you did a medical interview. The medical interview, you're just going over medical history, is that right?
Medical history, what he recalls of his childhood, looking to see how his memories match up with the rest of the record, asking about what he recalled of his school experiences, his mental health, his substance use, that sort of thing.
Were you ever given any records as to what actually occurred in this case?
Yes.
Okay, can you tell us what records you had regarding what actually occurred in this case?
They are in the back of my addendum, and there was a lot of material, I believe, from your office that I reviewed as well.
Tell us what kind of materials you're talking about.
That was the video and audio from the truck, as well as some breakdowns of that. And I think there were some timeline summaries from your office as well.
And on those items, did you watch all of those?
Yes.
Okay. And did you watch, what you were provided, did that include only the day of the abduction, murder of Athena Strand, or did it include all 5 days of videos that were available for you to be able to review?
I know that there was material from before and after the offense. I don't know if I have all of it that your office has, but I know there was material from before and after.
So for instance, were you aware that the defendant had covered up the video showing what the van could see forward, looking forward, prior to the date of the abduction, kidnapping, sexual assault, and murder of Athena Strand.
I recall some times where he covered the camera. My impression it was because he wanted to smoke or do something around the vehicle, but I'm not sure if I recall what you just said.
Well, I guess where did you get the idea?
Objection, Your Honor, relevance. This doesn't have anything to do with this diagnosis.
Where you headed?
I'm trying to figure out what he's reviewed and what he knows about this case.
Okay, just ask him.
All right. So you've reviewed the days before, so you're aware of what took place in those days.
It may be incomplete, but I did see some stills and video from before.
Okay. And then as far as the days after, as far as what he did on those days after in those videos, meaning December 1st, December 2nd, the day he was arrested, did you review those as well?
I don't know that I reviewed everything that you have. I recall a little bit of material from after the event.
Okay. And I just want to lay the groundwork because I want to talk about how his NDAE and the comorbid other things, that risk factors that I think you listed out, may have been on display or not during the facts of this case. All right?
Sure.
Does that make sense?
Yes.
All right. So let's just talk about, first of all, your diagnosis. Because ultimately you made a diagnosis that boils down to one sentence. And then the other things are related to more of the comorbid or the, what do you call it, the differential diagnosis. Is that right?
I mean, a diagnosis is generally pretty short, so if we boil it down to the diagnosis, it's 4 words, but I did write a pretty long report.
I understand. But a lot of that was talking about other things other than fetal alcohol syndrome or fetal alcohol spectrum disorder, correct?
Yes, I tried to be comprehensive and look at the other risk factors.
Understood. And then, so let's talk about your diagnosis. I believe that the bottom line diagnosis, which is contained right there on page number 1 of your report, was that, in my opinion, to a reasonable degree of medical certainty, that Mr. Horner has neurodevelopmental disorder, alcohol exposed. Is that right?
Yes.
All right. Now, that is not fetal alcohol syndrome, correct?
Correct.
So, to a reasonable degree of medical certainty, you can testify to this jury right now that Tanner Horner, the defendant in this case, the person who has been pled guilty to killing Athena Strand, did not have fetal alcohol syndrome. Is that correct?
Correct.
All right. Secondly, there's another level before you get down to the level of NDAE, and you called that static encephalopathy. Is that right?
Yes.
SEAE?
Yes.
And Tanner Horner does not have SEAE, correct?
No, as I testified, he came close to it, but I judged him to have the more moderate brain impairment.
And to a reasonable degree of medical certainty, you can testify to this jury right now under oath that Tanner Horner did not have severe brain damage, correct? Or severe brain impact.
Yes.
Okay. So let's get down to the actual diagnosis. Now, of the 3 diagnoses that you're talking about, although it is the most common, it is in fact the least serious as far as brain impacts go among the different things that are listed under the umbrella of fetal alcohol spectrum disorder. Is that right?
If I can quibble with you, it does involve a lower level of confirmed brain dysfunction, but as I was testifying on direct, people who have this diagnosis may fare worse in life because they go through life with that invisible disability.
Do you think, based upon the records, that Tanner Horner's disability was invisible? He had a lot of interventions, don't you agree?
He received interventions for autism and ADHD. I think the FASD part was missed.
Okay.
And
Go ahead.
May I finish? And I noted that he received interventions at school and sometimes in mental health, but I don't feel that he had the level of support and structure he needed at home, which is maybe the most important of those three.
And I understand that at least after the 6th grade, would you agree that he had a fairly stable home life compared to many people that have this same sort of dysfunction? Would you agree?
I think things got a lot better for him in 6th grade when he was essentially permanently with his grandmother and Bill. But I know that his mother was coming in and out of his life and that there was a fair bit of chaos with that was difficult for him.
But you would agree that he had stability compared to a lot of people that you see that have these type of disabilities. Would you agree?
Yes, from 6th grade on, things did get better.
So, knowing that, let's just go into the idea of the different, the areas of significant impact. Now, you talked several times about ADHD, and what does that stand for?
Attention Deficit Hyperactivity Disorder.
And do you have some experience with that?
A lot.
Okay. Personal and professional?
You name it. Yes, I have a lot of children in my practice with ADHD, and I'm pretty familiar with it at home as well.
Okay. And understanding that, that can be a significant impairment, but it also is not debilitating for most people. Would you agree?
It depends. As I was saying earlier, if you have ADHD because of heavy drinking in the first trimester, it tends to be harder to manage. The meds don't work as well on average, and it can be more difficult into adulthood.
Okay. So that's an area, but it's an area that there is lots of treatments and therapies and other things that are available. Would you agree that Tanner Horner availed himself to many treatments and therapies along the way to deal with his ADHD?
He tried a number of medications, yes.
Not just medications, but at school and at home, and had intervention of multiple different people to help him through that diagnosis. Would you agree?
I wouldn't say that at home he got a lot of support for his neurodevelopmental differences. I got the impression that his grandparents maybe didn't understand or believe in that as much as some other folks do.
And where are you getting this from?
The records.
What records are saying that his parents didn't believe it, that he had ADHD or that he needed help?
I recall that Mr. Horner told me that Bill, his grandmother's partner, husband, didn't really understand autism and thought he just needed to be different. And I think he also told me that his grandmother didn't really understand neurodiversity or autism.
So this is coming from Tanner Horner, the person that you were examining, that you're getting these facts from?
Yes, and if I may be recalling incorrectly, but I believe that Dr. Ryan had some interviews with family members that had similar information.
Okay. So, but you didn't talk to any collateral sources?
No.
And what you had at your disposal, other than the records that you went through, was this social history written by the defense?
I had lots of things, and that was one of many records.
Okay. So with regard to the areas of significant impairment, Tanner Horner was tested for IQ when he was 18 or 19 years old, is that correct?
Yes.
All right, and at that time, would you agree that was part of a determination as to whether or not he was still going to be eligible to receive benefits based upon his previous diagnosis of Asperger's?
Yes, it was a social security disability evaluation. I don't know if it was to rule in or rule out Asperger's, but I know it was to determine whether he should continue to receive benefits as an adult.
And you also know that as a result of that examination, at that time, that the United States government decided that he
Objection, testifying.
Let me hear the question.
Do you know as to whether or not his benefits were denied based upon that evaluation?
I did read that evaluation, yes.
And were they denied?
They were.
So he had been receiving benefits up until a certain period of time, and then after the evaluation that was done when he was 18 years old, the benefits were no longer available to Mr. Horner, correct?
Yes, and I have to say that was a very
Objection
inadequate.
non-responsive.
Sustained.
With regard to that, at that time, there was a report issued by Dr. Cleves regarding her examination, correct?
Yes,
And you had that as part of your, part of what you had available to make your determinations, correct?
I did.
And in that report, would you agree with me? Do you have that with you?
Not on me. I have, no.
Well, I'll just ask you if you have any quibble with what I'm saying. I'm going to ask you to tell me, all right? That as part of that, he had a full-scale IQ of 102. Is that right?
I do have that data, so I'm just going to double check. Yes.
And can you tell us whether or not that is higher or lower than the average person?
That is right in the middle.
Okay. But it is, average is 100, is that right?
Yes.
So he had 102.
Sure.
Did you retest him?
He was retested by Dr. Kaufman in 2025.
Okay, so since between the time of this offense and today, he was retested again. Did his IQ go up or down?
The trouble with the summary score is the significant splits I talked about.
Objection non-responsive, Your Honor.
Sustained.
Your Honor, can we approach?
Dr. Davies, would you agree that when he was 18 years old, as part of this testing procedure, that he had a verbal comprehension index of 107?
Yes.
And now we've talked all about the fact that Tanner Horner can't understand what anybody's saying to him or what the nonverbal cues or anything else. Is that verbal comprehension index indicate that to you?
No.
Okay. Is that higher or lower than average?
107 is just above, right above average if you include the standard error of measurement, which is about 5.
Okay. And on that same test, he had a perceptual reasoning index of 113. Is that right?
Yes.
Is that higher or lower than average?
Higher.
Now, I realize that he had some other indexes that were lower. Working memory index of 97. Is that right?
Yes.
Is that still within the normal range of plus or minus from 100?
Yes.
Okay. And then the only one that he had that was lower than the normal range was the processing speed index. Is that right?
Yes, that was 81, which was a very large split between that and his verbal and nonverbal intelligence scores.
And you're saying that the fact that he had verbal comprehension index of 107, perceptual reasoning index of 113, but only processing speed of 81 is an area of significant concern for you?
Yes, because those are unusual splits seen in, if we see a split that's seen in less than 3% of the population, and if it's a split that is commonly seen in fetal alcohol impacted patients, we do consider that a significant finding.
Okay, so significant to you in that you are taking that into consideration as to whether or not he's been impacted by fetal alcohol. Is that right?
Significant in that way, and just statistically significant. These are unusual splits.
I understand they're unusual splits, but what I'm saying, you're not saying it's significant as to his behavior per se. just as to whether or not he's been affected by fetal alcohol?
I think that if you have significant splits and they are part of an FASD diagnosis, then yes, that diagnosis is significant to your behavior.
Let's talk about Dr. Kaufman's report, because I don't have that in front of me. What kind of verbal comprehension did he have with Dr. Kaufman's? Well, first of all, what was his full-scale IQ with Dr. Kaufman?
A full-scale IQ is listed.
What
but
is it?
It's 103.
Okay. I understand that's within the standard deviation of normal now, is that right?
Yes.
All right, so he had normal IQ, still 1 point higher than what he tested before, is that right?
I would have to say not really.
Okay. Well, what was his verbal comprehension index on Dr. Kaufman's?
98.
Okay, so it dropped from 107 to 98, is that right?
Yes.
Okay. Does that indicate anything to you?
Not a lot. They were different. There was the 4th edition and the 5th edition, and you can see some score variation like that.
Is that sometimes also accountable to something called malingering?
It could be, but I didn't have any indication of malingering on the malingering test that Dr. Kaufman did.
Well, I'm asking you as a medical doctor, is the fact that this person's IQ is tested, and then later after they've committed some type of horrible crime, it tests almost 10 points lower, can that be evidence of malingering to you?
I'll leave that as it could be.
Okay. What about his perceptual reasoning index?
That one, sorry, he had a visual, in this edition it's called the visual spatial index, and there it was 122.
Okay, so that went way up, is that right?
Which would argue against malingering, yes.
Okay, so, I understand what you're saying, it argues against malingering, but it's drastically different from the other one.
Yes, on a different edition of the IQ test.
Okay. So, what were the other indexes on Dr. Kaufman's report?
The fluid reasoning index was 105. Working memory was 106. Processing speed was a lot lower, again at 89.
Okay, so, but it was higher. It was 89 versus 81. Is that, could it be from the different tests, is that right?
Yes.
But it's a lot closer to normal in that test than the other ones, right? Is that right?
Yes, and again, I'm more focused on the very large and unusual splits.
And I think you've explained that, but bottom line, the defendant has a normal, if not above average IQ.
His IQ tests aren't normal because of the splits, and the psychologists that I work with routinely wouldn't give a full-scale IQ when you have a large difference between the verbal and nonverbal IQ. That's just what I've been trying to share.
We have two different psychologists, Dr. Gleaves and Dr. Kaufman, that both have given a full-scale IQ, is that right?
Yes.
Okay. So that was the next thing. Then those were the areas of significant impact. So ADHD and the unusual splits in his intellectual functioning test, but you amended that later, is that right?
Right, with the additional confirmation of autism by multiple experts and the additional in-depth language testing from Dr. Fritz.
So you moved that one down from significant impairment, the multiple splits one,
Yes.
to borderline.
Correct.
All right. And then you moved up Asperger's / autism spectrum disorder level 1 to the more significant level, based upon Dr. Fritz's report.
No, not just autism. It's autism and language. And it was based on Dr. Fritz's report and the reports of Dr. Spence and Imhoff, who also diagnosed autism.
Did you put a notation in your report that Mr. Horner's functioning in the domains of ASD or Asperger's was not clearly impaired on neuropsychological testing?
I don't recall writing it that way. What I was communicating in my original report was that we had records of autism diagnoses during many years during his childhood, but unfortunately the original diagnosis records no longer existed. And so I could tell that he'd been receiving services for autism through the school district for the second half of his school career, but I didn't yet have the adult autism evaluations that I now have when I wrote that.
So based upon those other experts' reports that were later provided to you, then you moved that one from borderline to significant for you?
Yes,
Okay.
with the confirmation of autism and the additional language impairments.
Okay. And so with regard to some of the, what you said, areas of concern, you listed motor tasks. And there were two things that you listed, correct?
Yes, finger tapping and grip strength scores.
You understand that this defendant pled guilty to strangling a 7-year-old girl successfully. Is there some type of grip strength issue there?
We've all heard the video, and I'm sorry to say this, but it took a long time. So I don't think that the video really makes the point that you're trying to make.
No, well, I'm not trying to make a point other than the fact that he had to use his grip strength in the commission of this crime. Would you agree?
To some degree, yes.
Now, you also said finger tapping. What kind of instruments does this guy play?
Drums.
Does it make sense someone would be tapping their fingers if they're a drummer?
I think that the finger tapping task that the neuropsychologists use is different from what drummers do.
You think it is or you know it is?
Well, it's more about rapid finger tapping, and I think that drumming skills are more about rhythm and using more of your arm, is my impression of that test.
So, we already talked about NDAE being the least serious as far as brain damage, I guess I would say.
It's in the moderate impairments, yes.
Now, let's talk about the other, quickly, talk about the other neurodevelopment risk factors for the defendant. You said there was a parental history of addiction, use of other substances by Melissa Horner during gestation, which you don't have an opinion as to how that might have affected him, but you're saying it might have affected him. Is that right?
I think I talked about how it might have affected him on direct.
Well, you didn't have any clear delineation as to how that plays into all this. You just said that it was a factor. Is that
A
right?
potential factor,
Okay.
but not generally as risky as alcohol.
And childhood adversities, and then the diagnosis of autism. Now, you said autism in your report, and I just want to make sure, just like we have this umbrella term of FASD, and you have 3 different things. It could be fetal alcohol syndrome, which is very, very serious, correct?
Yes,
And then you have the other one, SEAE, right?
yes,
And that one involves severe brain damage, correct?
yes,
And then you have this latest one, NDAE, and that's just either mild or moderate, and you're saying it's moderate in this case.
yes.
All right. But it's the least serious of the 3 as far as brain damage.
As far as measurable neurofunction, yes.
Okay. So does, you talked about head injuries and then substance abuse. There's a number of different substances that Mr. Horner, the defendant in this case, told you about. Alcohol, marijuana, K2, MDMA, LSD, mushrooms, cocaine. Is that right?
Yes.
Now, other than alcohol, are all of these commonly used illegal recreational drugs?
I wouldn't say commonly, but they're certainly used.
Do you consider the regular use of illegal drugs to be criminal activity?
Yes,
Okay. Is supplying illegal drugs to other individuals criminal activity?
Objection.
I'm not-
For legal conclusion, not a derivation.
Sustain.
Well, in evaluating people as a physician for pathology and their personality, you have to know whether somebody is a good candidate for probation or parole, correct?
I don't get
Objection,
in.
This witness is a pediatrician.
Sustain.
All right, so in using, with regard to, I'm going to just get to the part about the possible brain injuries that may have occurred as a result of fetal alcohol syndrome disorder. Is that right? I mean, is that what you call it, fetal alcohol?
Fetal alcohol spectrum disorder.
Disorder, because he does not have fetal alcohol syndrome.
Correct.
Right, okay. So the first thing you said was lower IQ. We've already dealt with that. He does not have a lower IQ, correct?
No, he has significant splits on his IQ.
Understood. So let's talk about ADHD. Does ADHD cause people to commit the act of murder?
That's an unusual outcome for ADHD.
Are you saying there's any causative effect to the murder of Athena Strand, in this case by Tanner Horner?
From ADHD?
Yes.
I can't use ADHD to explain what he did, but it's possible that impulsivity may have played a role.
And that would have to be based upon the evidence in the case, correct? Whether it was impulsive or not impulsive.
Judge, objection, legal conclusion again.
Overruled, I'll let him answer that.
Yes, my consultative question was not what happened in that van. What it is, does he have a fetal alcohol spectrum disorder?
And are people with ADHD able to have productive and fruitful and nonviolent lives?
They are able to, yes.
You also talked about language and social difficulties. You've watched the videos. Does it take language and social skills to convince an unsuspecting gas station attendant to loan him some cleaning supplies to clean up the
Objection, Your Honor.
van?
Relevant.
I'm sorry?
Relevant, he's also calling for speculation and also calling for legal conclusion.
Speculation is sustained.
Okay. Would you agree with, on those videos, throughout them, all 5 days of it, that he exhibited multiple times of using his language and social skills correctly to accomplish goals that he wanted to accomplish?
I didn't see a lot of evidence in that, in the videos. I don't think asking for towels is a high-level language, use of language or social interaction.
What about calling your boss and making arrangements to make sure you still have control of the crime scene the next day?
It uses language, but I don't know that that taps some of his deficits.
Now, you talk about learning disabilities. He did have the diagnosis of autism. What are the specific learning disabilities that you saw in the education records?
Have I talked about learning disabilities?
Well, yeah, I believe that it was mentioned in your report.
Sure. In my report, what was notable from his school records is that his first category of qualification was for autism or Asperger's, but his special education services were also under learning disorder. And unfortunately, we didn't have enough detailed records. I think some were destroyed, that I don't know where that came from. So I included that in my report as, part of having learning being a possible area of concern, but I don't have the data that came from.
And you talked to Tanner Horner about that, and he told you that he didn't have any learning disabilities, correct?
I'm sorry, I just don't recall what he said, so I want to make sure I'm right.
To be under the developmental and academic history.
Sure. Yes, he didn't recall learning disabilities, but Spanish was harder for him. That's what he said.
And in parentheses, he said probably because he was sleeping in first period, correct?
Yes.
What about, we talked about visual spatial deficits?
That it was an area of concern, yes.
Okay. But on the visual spatial test that Dr. Cochran gave him, you said that he was unusually high.
Oh, so that you're talking about visual problem solving or visual intelligence, and the visual spatial domain that we're talking about, I believe, is copying a complex figure, which is considered differently from intelligence when we're looking at brain domains. And the ability to copy a complex figure is something that the neuropsychologists consider a visual spatial function rather than an intelligence function.
With regard to, what do you mean when you say novel problem solving?
That if you're presented with a new type of problem that you haven't practiced or done before, that your frontal lobes or executive skills get involved to kind of figure out, okay, what's this about? What's my strategy? Is my strategy working? Checking your work, that sort of thing. So it's less of a rote answer and more executive skills required.
And you said that was an area of concern for you.
I said that his executive skills were an area of concern because some scores were average or above, but some were in the 3rd to 16th percentile.
Well, I believe I went down and wrote the ones down that you said that were a concern.
Sure.
And novel problem solving is one of them, is that right?
I think you might be getting that from the FASD background part of my report, where I'm talking about general areas of difficulty.
Okay, so this
Yeah.
is not specific to Tanner Horn.
No, he had other executive skills that were in the area of concern range.
But novel problem solving was not one of Tanner Horner's problems, is that right?
On the testing that I reviewed, no.
And throughout this case, he's presented numerous different lies to meet different types of evidence as they came forward. Would you agree?
I think so. I haven't reviewed as much of the police interview type of history of the case.
Well, I mean, the fact that he told them that he backed into her and then freaked out because of his autism, that's a novel problem solving. Would you agree?
It's an excuse that didn't hold up.
But it was one that he tried. It was a way that he tried to solve that problem, correct?
He did try to lie about what happened, and the video didn't back that up.
And you are aware now that he's also saying that now he has a reason for covering up the videos because he was using cocaine.
I'm not aware of that.
Oh, I thought you said you had some indication that's why he was covering up the video.
Oh, I thought he was smoking cannabis on one of those, but maybe I'm wrong.
Well, you saw him smoking cannabis on one of those, correct?
I think so.
Yeah. So that was on the video,
Okay.
right? There was never any cocaine on the video. Would you agree?
Not that I recall, but smoking cannabis on video isn't great problem solving.
Yeah, I understand that. But making up a story to cover new evidence is problem solving. Would you agree?
It's lying or it's problem solving, and I think we're here today because it wasn't effective.
The last thing I want to talk about is zero, because you're, as a physician, you know what malingering is, correct?
Yes.
And that is making up some type of psychosis as an excuse to mislead or gain some favor with the police. Is that right?
Objection, Your Honor, testifying. I don't think any of the experts would define malingering that way.
Well, you define malingering.
Malingering is either exaggerating psychiatric symptoms for gain or faking bad on neuropsychological testing, things like that.
So if you get caught for murdering a 7-year-old girl after you sexually assaulted her, and you make up this alternative personality to show that you're just crazy, so that maybe they might find you insane at some point, is that malingering?
It's an attempt at malingering that I don't think was very effective.
Okay, thank you. I'll pass it.
Thank you, Your Honor. Dr. Davies, could you pull up the chart that Dr. Connor prepared?
Sure.
A couple of, let's start with kind of the basics of IQ. You mentioned something about a 5-point plus or minus. What were you talking about there?
That when you do a psychological test and you get a score, there's usually a range of error where the psychologist might say he got a 102, but his score is probably somewhere between a 97 to a 107 type of thing.
Okay, and a good example of that was we had 2 scores that were 9 points apart.
Right.
So the average IQ for someone from the United States would be 100 plus or minus.
Right.
So it's up to 105 and down to 95.
And it depends on the test, how big that range of error is, but something like that, yes.
And you mentioned that, but everyone might not understand. There's a newer version of that IQ test.
Yes.
Can you, so when you said something about 4 and 5, just
Right.
illustrate what that was.
So the Wessler Adult Intelligence Scale, in 2009, it was the 4th edition, and in 2025, it was the 5th edition. And so there's there's new questions. They've organized the results differently. So I expect that when someone takes a new edition of a test, that they're not going to get the exact same score that they got the last time.
Now, we didn't read through them, but Mr. Berry had you reading through. Matt, or John.
Yes, sir.
These little words down here that I'm sure you can't see from the other side of the room, were these the things that Mr. Berry was asking you to read the scores?
Yes, those tiny bits of text are the individual tests that relate to the score that's plotted above. And so on the far left is the IQ, and those were the IQ subtest scores.
Okay. So you get your IQ over here, and then each one of these is one of these dots, right?
Right.
And you said this green line is,
Average.
and this is,
1 standard deviation below the mean, which means the bottom 16th percentile of people who take that test.
so for example here, when he's reading off these scores, you've got a score that's here, well below this red line, and then a score that's way up here.
Yes.
Is that what you're saying is unusual?
That's a pretty big variability, and it's a hallmark pattern that we see in FASD.
But there's no reason to think if he takes this test twice, would his IQ fall within that standard deviation? The overall IQ?
I'm not sure I understand your question. Sorry.
I'm sorry, maybe a bad question. We're seeing that he has deficits. If
Yeah.
this is accurate, the next time he takes this test, he'll probably have a deficit in that area too.
Yes, unless it's the same test and he's practiced it, so he's getting better. But in general, we expect these to show up over
I
time.
was ignoring the practice effect, but yes, there's a practice effect, and
Yeah.
would you just tell the jury what that is?
So practice effect is, you're not allowed to give someone a test within a certain time interval from when they've just taken it, because they've practiced it, and we expect that you're going to do better.
Okay, so ignoring the practice effect, if this test is accurate, he's going to be within that range over and over again, and his IQ total is going to be within the range.
Yes, plus or minus some points, because we expect some variation, but the overall pattern would likely hold.
And NDAE is under that umbrella of FASD, correct?
It is broadly considered under that umbrella term, fetal alcohol spectrum disorders.
And you actually have a clinic to treat FASDs,
Yes.
and you have patients that are only diagnosed with NDAE who are coming to that clinic for help.
Yes, and the people who come to the FAS clinic are coming for diagnosis and recommendations. The treatment part is happening in the community, and I have a number of those patients in my practice.
And you said about what percentage of your practice are the NDAE?
Of people that come to us for diagnosis, just over 50% have NDAE.
Now, as part of your work on this case, were you asked to render an opinion on insanity or any other defense?
No.
Were you asked to render an opinion on whether or not Tanner Horner has an FASD?
Yes.
Pass it on, Sean.
Briefly, Mr. Beery,
No further questions, Your Honor.
may Dr. Davies be finally excused?
Yes, sir.
Thank you, Doctor.
Thank you.